Uh, Good day to you, Philip. How are you? Mm, yes, things are going not really well because past 2 weeks we've got not less than 4,000 cases each day. That's too much for our small population. And yes, my clinic is in Georgia. It is in Tbilisi, obviously, in Georgia. It's a big pink clinic near your university campus. So whenever you happen to be in Georgia, I'd like you to, I would say, um, yeah, to see you there too, to attend the surgeries. The surgeries are going on, except the planned ones, but oncology, like the tumors, cancers, just the same, and emergency surgeries, obviously. Uh, but the emergency surgeries are, so frequency of them is increased because of the majority of the clinics are in a lockdown. I mean, they are converted into the corona centers, but our clinic is still not admitting corona patients unless they need an emergency help. Yeah, we're transferring the patients after the we get the test results to the specified clinics. But if the pandemic situation goes on this way, if we keep like 4,000, 5,000 every day, then we will have to admit current patients. We will have no other choice. Okay. So my chief and his wife are back, and I'm no longer um yeah, on weekends and on Tuesdays I'm at home. The rest of the days and nights, including I'm at the hospital. Yes, yesterday I had a really tough shift. The Mondays are usually toughest. Uh, it's nice to see you, Philippe. Welcome, Faki. Um, yeah, that's pretty it. You have any more questions? Philip, are you in Georgia? I remember you asked me you wanted to attend surgeries. Oh, you're in Georgia. So, and then you should know that near the campus there is a big pink clinic called the Shauri National Medical Center, and that's my clinic. That's where I work. Yeah. Oh, yeah, yeah, just down the street, from the campus. Yes, where the bus stops are, behind of the one of the stops. Yeah, the biggest building. It is now renovated, no longer is gonna be pink, but that one, yes. Yes, exactly. So we are on the sixth floor, neurosurgery and neurology. But now, unfortunately, we're not allowed to have any students there, because it's not safe, because everyone is considered to be the risk of carrying the coronavirus, and there is no public transport. We're traveling through our hospitals, I would say, vehicles. And yes, as you know, my chief and his wife and his family all suffered from corona. He was in ICU due to bilateral pneumonia, though he is really young and healthy, no smoker, no other chronic disease at all, but he really suffered a lot because of pneumonia. And even now, he's getting exhausted very, very quickly. And when we used to have two, three surgeries in a day, now one, only one surgery. Yeah, that's unfortunate outcomes because of corona. Yeah. Hello, Ahmed. Hello, welcome. Hello, Cookie. I hope you're all doing well. So today's lecture is going to be really short because we've got 3 weeks left and we've got three topics left. So these topics, which I have to two parts to discuss them on Tuesday and two Saturdays. So I will discuss a small part today, and the next part we're going to see on Saturday. And once again, you've got next week, or I guess you've got the second midterm coming up closer. So so I will again repeat which of the chapters will be included. This will be okay. This will be starting from the immune disease. We're gonna have inflammatory reactive infectious disease. We're gonna have hyperplasias, hamartomas tumors, non-neoplasms, genetic disease, which we have talked about last Saturday. So that's it. This is going to be all of the second midterms material. And today we're going to talk about odontogenic cysts. And next Saturday we're going to talk about non-odontogenic cysts and odontogenic tumors. And we've got we will have 2 more weeks, which we're going to discuss this following topics. Okay, we are well suited in a table, and we've time schedule. We're doing just fine. Okay, is there anything you want to ask about the previous lectures material, genetic disease, I mean, or was everything clear? Everything was clear. Thank you, Philip, for your response. Thank you, Cookie. I'm glad to hear that. That was quite simple, and it was like a shout out to the molecular biology and genetics, which I suppose you have already gone through. So I'm not gonna waste any more of your time. I'm just gonna open up the new PPT, which, by the way, will be uploaded after Saturday, after we conclude this topic. Okay, so don't wait out for this. Just study the material we have already gone through, then start to prepare for the midterm, because when you the week before or the day before, it is a lot, but if you I'd say divide it day by day, it is quite not that much. I know a book is a big, and the material is quite stressing. You should be able to handle it accordingly. Okay, so it's not gonna get any easier. I would like to warn you, only harder, but much more pleasant than it is. Okay, because you'll be satisfied with yourself and with your knowledge, and you will do the job you love and you chose to do. Okay, so enough with the pathos and go back to the subject. We're going to talk about, as I said, odontogenic cysts, and about non-odontogenic cysts and tumors. I'm going to talk about on Saturday. So let's get started. So we've got different types of cysts, starting from radicular cysts, the that will give it. Okay, that we any I would say capsule having its content. Okay, so in the radicular cyst is so if you see the teeth here, you see here, and the shining picture, and that's the small cyst here, a radicular cyst. So odontogenic cysts can be broadly divided into developmental cysts and inflammatory types based on their etiology. And etiology, we know what it is. Etiology is the reason they came from the cause, or why they exist in the first place. Within their maybe developmental, but during their radicular development, there is some of the cyst, or during inflammatory response, the collection of the cells, the drives the formation of the cyst. Okay, so inflammatory odontogenic cysts include the radicular cyst and the lateral periodontal cysts, and they differ. They are in the ideas. They have the same features, but they're different from each other because of the location. Okay, radicular cyst looks like this, and periodontal, I mean, yeah, that's much likely to be called. Okay, but both of them are their etiology comes from inflammation. They are inflammatory odontogenic cysts. Okay, radicular cyst, which is otherwise called apical periodontal cyst, located at the apex of the teeth, or dental root cyst, dental root and cyst. Both of them, if you read in the literature, they mean the radicular cyst, apical periodontal, and dental root and cyst. Okay, both of them mean radicular cysts. Their most common inflammatory odontogenesis of the tooth-bearing areas of the jaws. Okay, if there is no radix, there is don't most frequently found at the apices of the involved teeth with infected or necrotic pulps. Okay, the contents of the cysts are usually inflammatory cells, or it could be infected or necrotic pulps. Okay, however, they may also be found on the lateral aspects of the root in relation to accessory root canal. If there exists one accessory root canal on me, then the cyst could be located to this part. So that's how, if you look from downside up, you see like, yeah, that's exactly how it looks like. On the X-ray, it was near the root, and this is how it looks like on the palate. Okay, palate surface. So this is the, yeah, I'm not sure if it's seen, but you can see here it's usually small, asymptomatic. It means no pain, no exudation or something, but may sometimes exhibit mild pain and sensitivity to percussion. Percussion means like this, yeah, sensitive. So when you palpate it or percussion from the tooth is usually non-vital, and the surrounding mucosa may exhibit bluish discoloration. Mucosa of the surrounding teeth, obviously, and tooth is probably needs to be extracted because it's no longer vital. Histopathologically, the radicular cyst is a chronic inflammatory lesion with a closed pathology cavity which contents could be infected partially or completely by non-keratinized stratified squamous epithelium that makes a capsule of the cyst. Okay, so let's see the case here. We've got a 32-year-old male patient with a chief symptom of mild pain and a pus discharge in relation to the left upper back tooth region. On the clinical examination, there was a massive palatal swelling with the pus discharge extending from the teeth 25 to 28, crossing the midline of the palate. So enlarged. The dental history revealed repeated prescription of the antibiotics and analgesics at private dental clinics for the same persistent swelling are remarkable. On palpitation, the lesion was soft and fluctuant, which also, I'd say, um, proved the idea that there was a pus in the contents. So the buccal vestibule was devoid of any swelling or draining sinus tract, and lymph nodes were non-palpable, and because of the chronic inflammation. If it was acute, then there will be swelling of the lymph nodes, and oral hygiene was poor with the grade 3 strains and cocculus. So let's see how it looks like. Yeah, teeth are in terrible condition, and this is the swelling I was referring to. This is the palpable, and the swelling was mildly painful, and the fluctuation means there is a fluid in the contents, and the fluid in this case was a pus. Oh, yeah. And the differential diagnosis of the radicular cyst should include dentigerous cyst 1, Pindeborg tumor, which we're going to talk about tumors, apical cementoma, which is calcified lesion, traumatic bone cyst could be, or ameloblastoma. We're going to talk about it also on Saturday. Odontogenic keratosis, today we're going to discuss it, and odontogenic fibroma. The cysts should be differed from the tumors and from premalignant lesions as well. So confirmatory diagnosis of the radicular cyst is established only after surgical biopsy and a histological examination of the lesion, which proves the diagnosis. Okay, either this proves it. Okay, I'm not sure there is a such word, but yeah. So this is what the histologic findings. So this is the content. This is the capsule of the cyst, and uh, yeah, somewhere here. See, there is a lack of tooth and some spacing here, and yes, that is how it looks like. Okay, so the patient was advised for surgical excision and biopsy to define the final diagnosis, obviously, and careful enucleation of the cyst was performed along with extraction of the 26 under local, so teeth, I mean, under local anesthesia. It means the injection of the local anesthetics like lidocaine, novocaine, and so on. And that is how it looks after open up the cyst cavity. There is a spoon-like tools which you clean off the surface of the cyst, and the contents are taken out and sent for the biopsy. Okay, and that is how it looks like. No longer that was the previous swelling. That is the place where they made an incision and cleaned it out, and that is after healing after 1 week. And yeah, follow up of the 1 week. Okay, that was it. No swelling. You see, the midline is corrected now. There was a midline because of the swelling. It was shifted, and now it is perfectly aligned in the middle. Okay. That was the first cyst, radicular cyst. Now let's talk about the residual cyst. Again, the cyst, but in case here we've got the residual cyst. How can we that different from radicular as long as it is also located near the radix? Okay, so the term residual cyst is used most often for retained radicular cysts from the tooth that have been removed. So the tooth is removed from here, and the residual it means in the place that there was a tooth before. Okay, so residual are among the molars, the jaws, and the location of all of the bony process presentations are really rare. It means out of the bony jaw, they quite rare. Okay, so let's see the case here. Yeah, you with the first eye, you can definitely see the difference asymmetry. The swelling is noticeable with the bare eyes, right? So we've got a 30-year-old male patient with a chief complaint of the slowly progressing swelling on the right side of the face for 5-month duration. Onset was insidious after the extraction of the decayed tooth from the same region. So that's the history that pushes us towards the residual cyst diagnosis. Okay, because history included the extraction of the tooth, and usually residual cysts are formed on the place of extracted tooth. Okay, so initially it was occasional mild pain was reported, especially under pressure and the forward bending of the head, and then medical history was not contributory. Okay, let's see from the side. That is how it looks like. If we look from the side, the swelling was bony hard in consistency, mildly tender on palpation, with no change in the local temperature. So there was no inflammation, just the bony consistent swelling, and the overlying skin was smooth, intact, without the redness, without the hidden, and appeared little stretched because of the mass underlying it. Now, the detailed head and neck examination did not reveal any significant findings. So there was no history of the. So, what was the diagnosis? Differential diagnosis included peripheral lesions of the jaw, starting from the neoplasm, ending with the tumors and cancers. Okay, then the CT was done. You see the CT, and here is the mass which we were talking about, and here is the mass. This is the mass. Okay, and this is the intrasurgical view. You see the incision is done right above yeah, you see. And here is exposed residual cyst. That was the reason for the swelling. Okay, and it was excised and it was cut into two, and that is the contents of the cyst. Okay, and that is the capsule of it. If we divide it into two, imagine like this. Okay. Okay, that was it. So now we've got a third type of cyst that is dentigerous cyst. Oh, yeah, you see here, dentigerous cyst. Here are the teeth that were not supposed to be here. Okay, changing. There is a tooth. Okay, and it's an epithelial line developmental cavity. Development, no longer inflammatory that the residual and the radicular ones were, but this is developmental cavity that encloses the crown of an unerupted tooth at the cemento-enamel junction. Okay, so the tooth that children all lose, and then the temporary tooth and the permanent ones, and in between this junction there's a formation of the dentigerous cyst. Okay, developmental cavity. It was reported first in the 1847 and 19th century. It was known as a distended capsule, osseous cyst, or the serous cyst, and these cysts are the second most common odontogenic cyst after radicular ones. So we've got the radicular, dentigerous, then residual. Okay, so oh yeah, so it develops by accumulation of the fluid between reduced enamel epithelium and enamel of within the enamel organ. Okay. The pressure exerted by an interrupting tooth or an impacted follicle obstructs the venous outflow, and this leads to the rapid transudation of the serum across the capillary walls. Okay, that's the mechanism. You don't need to get deep into just to know the reason. It increases in the hydrostatic pressure of the pooling fluid and leading to the separation of the follicle from the crown with or without reduced animal epithelium. An intrafollicular spread of the periapical inflammation from an deciduous tooth may also result in the development of the dentigerous cyst, the second in the frequency and after the radicular cyst. Okay, now let's see the case. Obviously, he got a 70-year-old male patient with a chief complaint of unpleasing appearance of the upper front teeth. Yeah, definitely unpleasing. And which he noticed since 5 years. So he was a child. Now he is a child too, but 12 years. Yeah, he was 12 years then. He gave a history of the retained maxillary anterior deciduous teeth, and there was no relevant past dental, medical, or family history, and there was no associated syndromes or systematic disease present. An intraoral examination revealed that his maxillary central and lateral incisors, maxillary mandibular canons, and the mandibular were unerupted. Okay, and here's the side view of the test. Yeah, alignment is a bit disturbed, but what is the most disturbing is that, yeah, this is the intraoral photograph showing expansion of the buccal cortical bone. Yeah, this is it in the relation of the right lower deciduous canyon and the second molar here and here too, not just the lower. And this panoramic radiograph is showing bilateral radiolucence in the maxilla and the mandible. Okay, that is how it is up. This is here, and this is down. You see? Yeah, and in here too. Okay, and a bony structure that shouldn't be here in 17-year-old individual. And that is you remember the normal city, how it's supposed to be all bony, and now you see the here is the teeth that shouldn't be here, and this is the denturous the cyst. Okay, around this teeth that shouldn't be here. Okay, that was the case. I don't know how it's resolved, but let's go on. So the next thing is odontogenic keratocyst. So keratocyst, yeah, that is which is lying here. Okay, this is here. Okay, why this is shiny? Because this is the teeth are fixed up. Okay, so odontogenic keratocysts, OKCs, they may occur in two different forms, either a solitary, which is called no syndromic odontogenic keratocysts, and the multiple odontogenic keratocysts, which is called syndromic. Okay, this is obviously the solitary, so not syndromic, solitary odontogenic keratocyst. Well, multiple odontogenic keratocysts usually occur as one of the findings in the Gorlin-Gold syndrome. Remember, Gorlin-Gold syndrome is characterized um, with the odontogenic cyst. Okay? Алло, تيخ مننا كيما تيخ окей, амწუჩი გაიხსნა ეგ არის. აჰა. აჰა. Oh, არ ვიცი, დავაზუსტებ, არ ვიცი და დაგესუსტებ. კი. კიდე ამის ისტორიის ნომერი მოგწეროთ მესენჯად, ეს ახლა გაიხსნა, სუბოლოო არის. კარგი. Sorry guys, sorry. I will be back in 10 minutes, okay? The work is calling. Be back in 10 minutes. Okay, my dear future doctors, let's get back to the subject. Uh, yeah, we were talking about the Gorlin-Gott syndrome, which is accompanied with the odontogenic keratocysts usually, and that is the multiple case of this sites. That is, the syndrome is characterized with, okay, with other features like skin carcinomas, rib, eye, and neurologic abnormalities all together, okay. Let's open up the PPT. And this is the solitary, and this is one of the Gorlin-Gold syndrome. Okay. The next one is basal cell nevus syndrome. The basal cell nevus syndrome, or Gorlin-Gold syndrome, which we have said about with keratocytes, is characterized by multiple early appearing basal cell carcinomas. And you see keratocytosis. It means that many of the keratocysts, multiple keratocysts of the mandible, and the anomalies of the ocular, skeletal, and the reproductive system as well. Here you see the multiple keratocytes. Okay, let me show this. So this is the part where multiple keratocytes are located, usually in the mandibular, okay, lower jaw. And the patients possessing a large number of the skin tumors associated with other typical clinical and X-ray anomalies of the NBCC. Okay, and the definitive treatment of the Gorlin-Gold syndrome, basal cell nevus syndrome, has yet to be established. However, early diagnosis is very important, as well as the periodical follow-up examination of the 10 patients, mainly due to the transformation of the skin lesions that may occur. Okay, let's see the case. Okay. So we've got a 20-year-old male patient with the chief complaint of swelling on the lower right and left back teeth region since 2 months. The swelling was initially smaller in size and gradually increased in size to attain the present dimensions, which we're going to see in the next slide. The history of the present illness revealed that there was swelling in the upper front teeth region 2 years back, for which he consulted a dentist, and upper front teeth were extracted. But the complaint persisted and never went off after the extraction of the teeth. So again, he visited the same dentist, and during the checkup, the other two swellings were diagnosed on the right and left back teeth region and adjacent to extracted teeth. The patient past medical history revealed a history of epileptic attack 2 months back. He is under medication and he did not have significant family history. So that was the panorama X-ray done of the jaw, and there was the brain. You see, it's darker, but it shouldn't be like this. So the complete clinical examination was carried out. Extraoral frontal bossing, depressed nasal bridge, ocular hypertolerance. Hypertolerance means that the eyes are apart from each other. It means they are far from the nasal bridge, and the prominent supraorbital ridge and mild mandibular prognathism. Prognathism means the protruding mandibular, protruding chin, were found that is the chest X-ray. So you see the calcifications on the ribs. Oh, and the involvement of the brain, of the ribs, and multiple cysts were located in the mandibular. In here, you see that all suggested the diagnosis towards the Corlin-Coral syndrome. Okay, and here are the teeth that were extracted. The cysts, multiple cysts that were extracted within the cysts from here. Okay, here, here as well. This is after the extraction, and these are I think these parts are from the ribs. Okay, yeah. Okay, that was Gorlin-Gold syndrome. Remember, basal nervous syndrome, characterized with a multiple Okay, that's all you should remember. Or cement of calcium in the content within the cyst. Okay, and it is seen as the bony structure. So this is COC, or calcifying odontogenic cyst. It's uncommon odontogenic lesion, which was described by the Gorley, the one with Gorlin-Goltz. You know, yeah, he has a quite a tribute to the contribution to the description of the cyst. Presence both in intraosseous, means the with the bony part central, and extraosseous, which is calcifying odontogenic cyst, is unilocular or multilocular, destructive radiolucent lesion that may contain irregular calcification. Radiolucent, it means they're visible just like teeth, they're visible on the x-ray, and with irregular calcification, somewhere it is darker, somewhere it's lighter, depends on the amount of the calcium it contains. The peripheral one, which is the extraosseous peripheral calcifying odontogenic cyst, presents less than 25 of all the calcifying. It means that less than fifth of the fourth of the cases, not the fifth. Okay, 1/4 of the cases is the peripheral. Okay, the rest 3/4 is the central. Let's talk about the case. We've got 11-year-old female patient complaining left premolar region, and the swelling was firm, painless, and sessile, covered by the normal oral mucosa, and was located in the vestibular gingiva between teeth 12 and 13, which were unerupted. There was no ability, no evidence of infection or periodontal defect on the either both rear near the swelling could be observed, and in the periepical and perioramic radiograph, panoramic radiograph, no osseous defect was observed. So the irregular calcification was noticed between the roots of teeth 12 and 30, and clinical radiographic differential diagnosis included the central ossifying, so that was the COC, calcifying odontogenic cyst, adenomatoid odontogenic cyst, calcifying epithelial odontogenic tumor, and odontoma, which is again tumor too. The lesions was surgically removed. So this is the lesion we were talking about. And you see here, this is the lesion, and this is after the you see the calcified part, like bony part inside it. It was surgically removed. I don't have follow-up pictures, but okay. So adenomatoid odontogenic cyst, which we should differ from COC, is the next one we're gonna talk about. Okay, and yeah, AOC, adenomatoid odontogenic cyst, it's a benign. The location is quite similar with COS. That's why we should differ. And this looks like it. Benign, slow-growing, relatively uncommon lesion of the odontogenic origin, and histogenesis of AOC is still uncertain. However, it is often considered as a hamartomous lesion rather than a true neoplasm. It is described as a cyst that has a hamartomous intraluminar proliferation of epithelial cells derived from Hartwig's epithelial root teeth. Sheath, sheath, yeah. It usually presents as an expansile lesion in the maxillary anterior region. An adenomatoid odontogenic cyst is characterized histopathologically as well remarcated cysts that typically appear with intraluminal masses. So all out of this blah blah blah, you should know that the location is similar to the COSC. That's why differential diagnosis includes COC, but the content is not the calcified one, but we've got adenomatoid epithelial cells within it. Okay. So, and the last one is the glandular odontogenic cyst, which is shown with the arrow, and GOC, glandular, adentomatoid, and calcifying. We've got three. This is the rare, uncommon jaw bone cyst of odontogenic origin, described by Gardner as a distinct entity at the end of the 20th century. A cyst having an unpredictable, potentially aggressive behavior and has a propensity to grow in large size with relatively high recurrence rate. That's why and they called aggressive because of their huge masses they can reach and their potential to reoccur. It poses a diagnostic challenge as it can be clinically and histopathologically confused with lateral periodontal cyst, with botryoid odontogenic cyst, radicular and residual cyst, with a mucous metaplasia, low-grade carcinoma, and a lot more that look like these. Okay, yeah. And the case here, which is a huge cyst, the glandular one, and then here, yeah, you see the huge cyst. So we've got 25-year-old male patient reported to our institution with a swelling in the lower left posterior left lower posterior region of the lower jaw for the 2 months that followed the extraction after the extraction. So we might think of residual cyst, but no, 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 no. The swelling was gradually increasing in size. That big residual cysts usually don't reach that much of mass. Medical history was not significant. Extraoral examination revealed swelling that was bony hard and non-tender palpitation. Overlying skin was normal, and submandibular lymph nodes were not palpable. Intraoral, so it doesn't give a sign to be a malignancy. Intraoral examination revealed swelling extending from the left second premolar to the second molar region, causing the expansion of the both buccal and lingual aspects of alveolar region. So this is the huge mass, definitely would cause that, and this is how it looks like. Intraoral examination, and this is the yeah, intrasurgically when you made it incision in here, and this is after the extraction. The huge cavity is left, and that is the mass that was extracted out of here, glandular odontomatoid cyst. Okay, and that's quite it. And that was all about today's material. Next week we're gonna next not the next week, but next Saturday we're gonna talk about the non-odontogenic cysts and odontogenic tumors. So that was it for today. I wish you a beautiful day. Have a nice week ahead of you, and see you on Saturday. Bye bye. Do you have any questions? I am always forgetting to ask you. Was everything clear? Okay, thank you. Thank you, thank you. Thank you, Philip. Thank you, Cookie, for being fair and faithful. Bye bye. I wish you a good week and have a nice day too. Bye bye. See you on Saturday. Bye.